I'll start off with a quote from one of my many mentors. Um, Rabbi Edwin Friedman, about 20 years ago, we were challenging each other in a parallel way, and he described leadership. And what Frank is demonstrating, what all of you can demonstrate, is leadership by Rabbi Friedman's eloquent, concise definition. By the way, he taught Protestant ministers 3-day workshops for 30 years on systems. So that was Rabbi Friedman. So he would say that a leader is a person that expresses a relatively sane but unpopular idea with the least amount of anxiety. So we can't twitch when we come up with a good idea. Frank is confident, so he does that, and we are considering you all leaders in that vein. My challenge was to say what I thought was the vision of family medicine of the future. You've heard a big chunk of it. What trains are coming down the track that might not be a light at the end of the tunnel without risk? And then what can we do to train teams for the family medicine practice of the future? That was what I was assigned, I think, by Val. So in that regard, what Frank says is what I think a number of us are doing is training the workforce, not just one specialty of family medicine, but in fact the team, whether professionally degreed teams. We have fellowships and those things that he mentioned for 2 years for the clinical psychologists and family therapists sometimes, and for the pharmacists. But what we're not doing yet that we need to stretch into are the community health workers and the community-based EMTs that need to be in the community in a more grounded way than we are with so many of our higher level professional degrees. What's making the difference on the triple aim is probably that. Is it more grounded, less technology, more connected, more reality-based interventions and support in the community? So what are the shifts that are coming? Well, what's expected is operational excellence from all educational practice and research systems. Operational excellence, not sloppy, not expensive beyond belief, but coherent, well-tuned systems. Your research teams and your practice teams and your education teams are being compared now to the rest of the world's industries. And we're not used to that. We're not lean in that sense. We're not efficient in many cases, and we're trying to be. We have to be relevant. When we talk about the things about teammates, maybe Wisconsin is similar to Minnesota. For us, those teams are in play. They're not just thought out by those of us in academia. There are very sophisticated practices that have very advanced teams in play. And in fact, in some cases, we're trying to catch up to those practices. We have entrepreneurs that leapfrog in quickly into gaps in care. So we have something that is a commercial name of Bluestone in Minnesota, invented by a family doc. On the one end, to care for the complex patients that can't get around well or literally dying at home. That if there's a triangle for the complex care at the top and the base, sort of almost not care, but real basic things on the bottom, those two ends are being squeezed now by entrepreneurs, and they're doing a good job. So at the top end are hotspotter teams that are assembling, probably in Wisconsin, but certainly in Minnesota and all over the country, and they're handed, I've talked to them and we work with them, our residents go spend time with them. Here's 100 of my most difficult, expensive patients, says company A, usually an insurance company, and they're dying out there at a very high price. We'll split it with you if you can save money and improve quality. And they do. But they don't have to carry the full load of a primary care practice or even a specialty practice with them. They've got a laptop and mostly social worker and an MA, and they go to it. And they do a very good job. They're saving lives that way and reducing costs. We're not quick enough, but we need to be quicker in that direction. On the bottom end, as you well know, CVS Pharmacy nationwide is doing a lot of things we claimed that we had to do. Guess what? They're going to be 10 minutes from everybody's home very quickly. And they actually do a good job. And that's taken the low sort of intensity care systems to the patient close to home, also not carrying all the infrastructure and weight that we have to carry in a regular office. So if you carve that out, it's like the innovator's dilemma. Those disruptive innovations at the top and bottom of care, what are we going to do in primary care? So we have to be adapted to deal with the leapfrogging that's going to go on henceforth. Very efficient care, but in segments. Unfortunately, what that does is fragment care. If we want to be successful, we have to meet the patient's need for rather quick access, convenience, but also connected on a relationship that we believe in. So the population-based health payments that we're all seeking are it's incumbent on us to reach the patients where they are. The good news about that triple aim and now quadruple aim with our friend writing that we have to attend to the needs and the experience of the provider teams. So that's the fourth aim of the triple aim. We have to make this an enjoyable experience. If there isn't laughter in the hallway once in a while or other things that are making it a positive experience, why would anybody come and do this? They can frankly do other things and have that happen. So we have to hit the triple and now quadruple aim with innovations and good work. And we have to obviously document things in an efficient way. And so we're all actually struggling with, we add another workforce layer of a scribe in order to help the providers get home or not. Well, we're trying to figure out efficient ways to do the work we've always done. And then we have to do all this in the face of teaching, as Frank was saying. So we believe that what the future that we're doing now, and we're entering that future rapidly, is interprofessional education and practice at the point of service, done in ambulatory and hospital settings. So at the hospital level, that team is actually more social work and nursing than it is physicians for those transitions to home. And we've recently become very active in that. Well, there are whole entrepreneurial teams that will come in and do that for you. Now, that won't link them to the relationship-based care that we represent in family medicine, but you can hire a consultant not just for running systems like this for education and learning as an organizational unit for strategy. You can hire somebody to come and do your transitions care. And they'll show up tomorrow morning if you call them. They're very nimble. And they aren't burdened with training. So we have to be nimble enough to be in that game and train people along the way. That's actually like juggling. You know, it's a little hard to do. So my image of this, if there were a metaphor, is that I like water. Frozen or not, I like water. And in Minnesota, we have a few lakes like you do, and then bigger bodies of water to the north of both of us. But if you're in a vessel, called maybe a boat, and you're rowing it by hand, adding another dozen rowers won't make that boat plain. Rowing faster won't make it plain either. It takes a second order change. It's very much like we need a designed vessel for primary care that's efficient, well designed. We need an efficient engine to drive it. That's teamwork, that's community based, listening to the public and what they need, not just what's convenient for us. So we're well into that. Again, in Minnesota, these teams are already in play. We are trying to lead, but actually they move so fast that what I thought was new yesterday is already being done. And they're on to the next layer of improvement. And I'm trying to teach along the way and catching up to what I thought was new, and it's already getting a little aged. So we better be nimble. I think to do that, we have to be, whether it's called lean or not, we have to standardize practices. I'm in the thick of that for now 5 or 6 years. We clinicians aren't always eager to standardize anything. Have you noticed that? And so how do we persuade people to come along and reduce the irrational variation in care and not crush creativity and encourage people to be sort of at their task in a relationship-based way, but also not do goofy, nonsensical things that waste time and energy and money and actually could leave our clinical enterprises behind when other entrepreneurs and efficient systems are moving ahead. So we have to be lean and nimble. And I think that's good. And to be team-based means we actually listen to people. And how many of us, including us, have really involved citizens or patients in the design of whether it's research or education or practice? We have advisory panels in all those areas. But it's humbling to listen carefully and have them tell us what they really think they need and want. And we say, no, you need B, and they say, no, I really need A. Now, there might be reasons for a difference, but to collaborate and get to some ground where we can agree and do it together is different than commanding people to show up between 8 and 5, to take this medicine whether you like it or not, to change your lifestyle because I told you so. It's sort of like motivational interviewing writ large at the institutional level. So that's like a different order change. It isn't rolling faster, it's being different in a well-designed vessel that has an efficient engine. And the fuel on that is engagement with the community, I think. So where we are, that's what's happening. And I know that I could ask a question now. How many of you are in practices where the model of payment is predominantly still fee-for-service? Fee-for-service. Look at that. So that means the majority of you will then raise your hand if you're in some population-based payment. Well, that wasn't true even a few years ago. That's how the world is changing. But our delivery systems with X number of visits, minutes per visit, et cetera, buildings that we work in, not the community, those are based mostly for fee-for-service billing. And if you're changing that fast, and I see that you are, that new world out there means getting it done in the triple aim manner with the quadruple aim of helping the provider teams be satisfied. So I'm excited that you're that far ahead, and we in Minnesota are mostly in teams now, mostly in large group practices, and actually only transitioning maybe a step behind you in population-based payment. The contracts right now that we've just come up with, that I met with this morning before I came here, our CEO of our practice said that they are writing contracts now for electronic visits, e-consults, and telephonic care. A year ago, just 12 months ago, that was on the horizon out there somewhere. That's here now. Given that, what team do we need? What facilities do we need? What kind of activities do we do to keep people well at a lower cost to their greater satisfaction? So I think the world is moving fast. If we can move fast with it, it'll be by teams. The good news for those of us involved in family medicine education is that people want what we produce, which are not only clinical care results, but clinicians of various kinds that Frank mentioned in various fields. They need them out there, right beyond the walls here. The public wants that outcome of a clinician and a teammate that can join them and lead the way in the kind of leadership that you're doing here. So I'm optimistic that you will and we will together produce those leaders in the model that Ed said of a good idea like Frank has, a relatively sane idea expressed with the least amount of anxiety. So that means we can't lose our grip when somebody says, "Oh, I don't want to do that," or, "You know, I think you're trying a crazy idea." We need to carry on and test that idea and adapt it as we go. And I think by doing that as you are today, you'll have a bright future and the blue sky will be possible, not just a fantasy. So thank you.